going to be opening the subcommittee hearing on Senate Bill 58 and then going into recess for about 5 minutes. We're waiting for one committee member to join us. We are now at a recess. Is there anyone who would like to speak on this bill? Out of recess. Yeah. Nobody?
We knew there was one out there.
Paula, good morning. Paula Minahan, Hospital Association. I guess we want to just kind of hear the conversation. And if you have any questions, we're here to answer your questions. You heard our testimony last week. We obviously are very supportive of the concept outlined in Senate Bill 58. As far as how we get to yes, I think is why we're here today. And we certainly want to ensure that all stakeholders are heard, but the goal is to ensure that our healthcare workers are protected in the situations that have been described. So I'm happy to answer any questions. And John Patty from CMC is also here, who's in charge of security, so can talk from a security officer perspective. But we're just really hopeful that we can pass something that can protect our healthcare workers.
Thank you. Anyone have any questions from the committee? No. Thank you.
I know you had some ideas on how to get there.
I believe your first name is John. I do have a few questions for you if you wouldn't mind stepping up, sir. Good morning.
So okay, got it.
Good. So one of the questions I have is, you're from CMC?
Yes, sir.
How do your security personnel handle, excuse me, let me read back that up. Is your security personnel in-house
Yes,
and they're not licensed through the state? They're under the exemption for security guard licensing?
correct.
Okay. What kind of training do your individuals receive or do you mandate?
So we go through a 120-hour field training. So, new employee will get 40 hours on each shift to go through, our policies and procedures, learning the hospital, typical training you would get for any organization. But then we have use of force training. We do carry equipment with us. We carry handcuffs, pepper gel, and tasers. So we go through a required training on that, and then we have annual recertification for that training as well.
So you maintain certifications for any use of force techniques that you use?
Yes, sir.
Thank you. Anyone have any other questions? Yes. Representative Muse?
When there is an incident in an emergency room, an incident like the ones we've been talking about in this hearing and others, what are security personnel instructed to do, and what are the medical personnel themselves instructed to do currently?
So, instructed. So our first, our main goal obviously is the safety of the staff and the patient, right? So when there are instances when there are physical assaults, we're asked to, I would say, maintain the order in the room, right? Because there are other, not only are we concerned with the patient involved and the clinical staff member involved, but there's other people in that area as well. So we have to make sure that the area is safe for them, right? So, we do have statutory protection to maintain that safety and decorum in there, which is something that we had sought a few years ago and was passed. So we have that protection, but clearly our role as security is to maintain the safety of everybody involved. So if that includes, physical force, non-deadly physical force, then that's what we would use.
Any follow-up?
And the medical personnel themselves, So I know this isn't something that, that people like to think about, but from what I understand, this is a fairly common occurrence in emergency rooms and hospitals these days. Um, how do you instruct a doctor or a nurse who is either concerned about being assaulted or who may find themselves in the position of being assaulted by a patient?
Sure. So we would like to take a proactive approach. You know, if we, no, I say we, if a clinician suspects that there may be a concern with the behavior of a patient, they will ask for us to stand by. But as you know, anybody knows just from, you know, common sense in living, right? These situations are volatile and can, you know, erupt at any moment. So we would always ask for them to take a proactive approach and ask for us to be there. However, in the event when something happens and it's not expected, we have certain policies and procedures that the medical staff would follow to call for our assistance.
And what specifically are they instructed to do?
So we have, you know, overhead codes that can be called. We also carry mobile safety pendants, right? So that similar to, you know, remember the old commercial, "I've fallen and I can't get up" type of thing, right? So if you recall, I don't know, probably 8 years ago, no, probably 9 or 10 years ago now, the nurse at the Elliott Hospital who was severely injured by a mental health patient. He was trying to get to a static alarm on the wall and couldn't get it. So when I got to CMC, we implemented this mobile pendant so that they can carry it with them. So if there's an event, right, they can press this and it alerts communications to what the problem is, and we're made aware of it to respond there. So, you know, they have options that they can take. You know, and again, proactive is the best approach. However, when that can't happen, we do have policies in place for that.
So I'm assuming that since you have the mobile pendants, security officer is not always present in areas like the emergency room?
So we try to be, you know, depending on staffing levels and calls for service throughout the organization. You know, we do, you know, roughly 40,000 calls, you know, for security every year. So, you know, we're busy based on, you know, our FTEs. So we're not always available there. It is one of our assigned posts from noon to midnight. You know, other organizations have different staffing structures that they use. But we also are responsible for the safety in our annex, which is where the IEA patients are held. So whenever we have an IEA patient, our resources are directed to that area. You're welcome.
Are you trying to ask whether the staff is instructed to evacuate or fight? Is that what you're trying to get at?
Not necessarily. I
Just trying
think
to figure out where we're going.
I think part of it is we've all sort of seen stuff like this on TV, but how things play out on TV isn't necessarily the way that they play out in reality. So I think what I was just trying to understand was I'm just trying to have a better mental picture of how security personnel and medical staff are supposed to react when something like this goes down, and I think that'll help us inform what we do here today.
Yeah, sure. You know, so if you picture, you know, an emergency room, whatever size, you know, we have 26 rooms, right? So it's not possible for us to be, you know, in every spot at every time. You know, with these situations going on at different moments, you know, we could be dealing with an issue, you know, one side of the ED, you know, and something happens on the other side, right? So, you know, no ED is big enough where you can't hear, you know, what's going on. So there could be a yell, you know, send security, right? So, you know, that message gets passed down, right? So it's just that we're not always available at that moment to be in the room with the clinician. Sure.
one more question. Um, do you typically have security cameras in areas like that where you can go back afterwards and track through what happened, or is there a patient confidentiality and issue that we need to be aware of there as well?
Yeah, so that's a delicate balance. Yes, of course, we can't have cameras in the patient care setting. So it depends on where in the hospital that this may happen. Yeah. You're welcome.
Representative Mannion?
Thank you, and thank you for taking my question. You mentioned earlier that there was an RSA change or a bill that passed a few years ago that allows hospital security a justification for physical force and detaining people. How would this bill, so that's already authorized, this bill would specifically allow non-security personnel, doctors, nurses and whatnot, those same protections? Am I understanding that correctly? Is that how you see this bill?
So that language, in this particular bill, I think was added because it seemed to match the language in the statute that it's trying to be placed under, right? We don't need that level of authority, right? So we have the authority to detain and maintain safety and decorum anyway. So that language isn't in there, and I think it's kind of taking away from the intention of this bill, right? The intention is to give the police more clarity to come in and make that warrantless arrest when the situation presents itself. My opinion on this, that language was, again, included in this bill only to match the language, for a merchant to detain a shoplifter. I don't think that that's necessarily required under this bill.
So, and then there's a separate amendment here that specifically, in a different RSA, that will place that authority for a law enforcement officer to make an arrest without a warrant based on your detention. I guess my question would be for healthcare providers in a scenario where they don't have security, a smaller hospital or doctor's office or something else. Do you think it would still be valuable to allow at least a justification for any healthcare provider to use some physical force to detain somebody? For those smaller agencies that don't have security.
Right.
I guess maybe that's what I'm thinking this is geared towards.
Well, I think, everybody, as you know, everybody has the right to defend themselves, and that, if that includes having to detain somebody until the threat is over, they're already protected by that. CMS has specific guidelines about detention and removing a restraint, as soon as possible, right? So, those are the guidelines that we follow as well. So as soon as the threat is over, that detention, can be released. So I'm not certain that there's any clinician who would really be interested in detaining somebody. Of course, it's unless for their own protection. But in the event of a hospital that has contract security, that's a different matter, I would think. However, they're still protected under that other statute.
Thank you.
You're welcome.
Any other questions?
One more.
Yes, sir.
Representative Muse?
In a situation where you have an incident and you've called the police, what is the procedure now? Does a security person detain the person if they're trying to get away? How does it work now?
So if they're trying to get away, right? The intention of this bill for me, right, is to provide the victim of the assault, which, a clinician here, right? Some type of protection. So if there's an assault and the patient runs out of the hospital, right? Then that threat to us, to the clinician, is gone, right? That's, from a security perspective, that's okay. From a clinician or a clinical perspective, probably not, right? So that's a different matter. So if we take an assault that happens and we call the police and they come in and, there's evidence of an assault, they do their investigation and, there's probable cause to believe that this crime has been committed. Well, it's a misdemeanor level offense. And, except for a few limited exceptions, they're not going to make that arrest. So again, just for a little bit of background, not to bore you guys, you know, in my years of law enforcement, I can't ever remember making an arrest based on this exception, you know, where the you predict future behavior. You know, it kind of the municipalities I worked for kind of saw that as a risk, right? You know, and so although it's on the books, wasn't always used for that reason. So you know, this is just some clarity to the police that they can arrest in this particular situation. So right now, if we call the police and they find that there's evidence of this misdemeanor level assault, they'll take the information, and if the victim wants to proceed with the matter, they'll request a warrant, an arrest warrant. You know, and I've heard testimony that, you know, it'd be okay just to, you know, take that approach. And I would say, depending on the size of the community, you know, the speed with which you can get a warrant differs greatly. You know, in my experience at Manchester Police, you know, it could take over a week to get a warrant sometimes, you know, based on this level of offense. You know, if you picture, you know, an officer going in, does the report, maybe goes on days off, comes back, you know, submits his request to the judge for warrant, has to be sent over to the court, reviewed. You know, it could be a little bit of time that goes by. It's not always the case where you can go to a you know, smaller community, you know, go to a JP and have that warrant signed right away. Doesn't always work that way.
Any other questions? I have one for follow-up. How many felony level offenses have you seen occur for assaults while your tenure at the CMC?
I'd say probably a half dozen.
They have been
Maybe.
arrested without a warrant.
They can be arrested without a warrant. So, you know, again, the victim still has the right to decide if they want to pursue. So, you know, the felony level, you know, with the serious bodily injury could be, you know, they don't know they may have a broken nose at the time, right? So, you know, it takes a little while, and then when the medical records are done, you know, that moment has passed. Yeah. So there are those. I've been, you know, as a police officer, I saw some felony level. So again, the felony level is covered. We're good with that. The majority of the assaults that we're dealing with are the misdemeanor level offenses, which still create a lot of anxiety.
Thank you.
You're welcome.
Any follow-up? Thank you.
No, thank you very much. I appreciate the attention this is getting.
Anyone else offered testimony? Please step up and identify yourself.
Good morning. I'm Karen Rosenberg. I'm the Policy Director at the Disability Rights Center. Thank you so much for your time this morning. Our concern is that there is a problem with workforce safety, but this is not the solution that matches that problem and appropriately addresses it. And the reason I say this is that when I think the situations we're talking about, for the most part, involve people who experience mental illness who are transported to a hospital on an involuntary emergency admission. They're in great psychological distress. And I don't think that this committee wants to criminalize that behavior. At the same time, we don't want our healthcare workforce put in danger. So I think there was a study committee about this issue, and one of the primary recommendations was that in all instances, wherever possible, that de-escalation techniques be practiced. So these warrantless arrests that we're talking about would occur after the healthcare workers already sustained an injury. So instead of focusing there, if we look to what's the root of the problem, we have a very distressed population, individuals who are experiencing significant mental illness, very disoriented, maybe, hearing voices, maybe really afraid. and their emotions, everything is escalated. So, but they need treatment. So if they are no longer presenting a danger, I don't know why we would want to, if they, they've flailed to try to avoid a restraint, for example, knocked a healthcare worker. Why would we want to criminalize that, divert them to the court system instead of trying to figure out a way to help them regain some composure and be able to get treatment? That healthcare worker already was hit. Instead, I think we need to work on providing the resources that healthcare workers require, the training to be able to know how to de-escalate, when to back off, support. They might need consulting services or support from psychiatric or psychological professionals. They may need some additional training, all manner of things to address the problem here, which is that we've got a really some volatile people who are experiencing mental illness who, if they aren't treated appropriately, could end up, in some unprivileged physical contact. That's what we're talking about here. And we don't want our healthcare workers subjected to that. We don't want our patients to have to be diverted to the criminal justice system unnecessarily.
Well, Representative Wheeler?
Thank you, Mr. Chairman. From your perspective, would you say that a better solution to this would be mental health institutions where we could place people who may have a need for a care but can't necessarily be in the care of someone who doesn't understand or have the right training to
I
care for
think there's
someone
like
that?
multiple things that need to happen in the ideal world. DRC, my organization, is not a real proponent of over institutionalization. I think part of the issue is that we don't have an adequate array of robust community-based services so that we can discharge people from our psychiatric hospital or from transitional housing into the community. So that's created this backdoor problem, right? We're not getting people out when they're ready to leave. The Department of Health and Human Services has publicly stated on multiple occasions that from New Hampshire Hospital has that they have about 60 people on any given day who are ready for discharge and not appropriate for that setting, but they don't have an appropriate place to discharge them to. And we do have some transitional housing, but it's become sort of a transition to nowhere, right? Because we don't have the step down for the people in transitional housing to make room for the people who are ready to leave the hospital. So that's one aspect of the problem. And, fundamentally, we need to be able to treat people in the community and provide services before someone gets to a crisis level of need. So that's another way to address the issue besides beds and housing and residential supports would be to have a more robust community-based services system. So those are things that need to happen. I understand that, we don't get to wave a magic wand and make that happen tomorrow. Too bad. But in the meantime, we know that we have this issue that is being worked on in various ways. So what can we do for the people who we know are going to for a while anyway, be in psychiatric distress because we know they exist. They're going to end up in our hospitals and they're not going to be in the right hospital and they're going to be in distress. At the same time, understanding that we don't want our healthcare workers put at risk. And this is, where I think we need to consider whether a warrantless arrest, expanding our warrantless arrest statute is actually going to address that problem. I don't see it addressing that problem. I see it removing some important civil rights that people have to not have a warrantless arrest, except in certain circumstances where there's, exigency. They're, going to flee like our current law says, if they're going to be destroying evidence, fleeing from the scene, which is unlikely at a hospital, or as was in the bill as introduced, where this concept was slightly expanded, where they are actually interfering with the delivery of medically necessary services and they're disrupting the hospital. So that's why the bill the language was developed the way it was, to recognize that maybe there would be this time when someone, despite all efforts, is continuing to really disrupt the ability of the facilities to do their job and treat people. And that's why the parties that came together, including my office, reluctantly thought, that may make sense as an expansion. But to expand our warrantless arrest law for misdemeanors, including times when the person is no longer, they're not leaving, we know who they are, they're not stealing the hospital stuff like a merchant situation, and they're no longer interfering with the operations of the hospital, why would we want to expand our law in such a way to divert those folks to the criminal justice system without a warrant? Remembering they can be arrested. It's just, the warrant process would have to be followed.
Representative Prue?
So, I have like 5 questions in my head for you. So, and I'm going to make a little statement first, but so I'm an EMT. I go into hospitals all the time. And because of the problems that you were talking about, I'm pretty sure our hospital staff has been trained to deal with the mental health issues, right? Because they're parked in there for days at a time. They're dealing with them. They've learned how to deal with them. They understand that. And I know as a mental health, as a provider of emergency care, a mental health person is flailing about and hits me because they have no idea what they're doing. I chalk that up to, I forgot to duck, right? And I'm not going to file a charge on them. The person I'm going to file a charge on that I want arrested and removed is the drunk who stood up, knelt up on the stretcher, cornered the nurse, and grabbed her multiple times until somebody came over and stopped him. And then when the security came, he was ready to go again. That guy needs to be removed, right? That guy needs to be arrested and gone. So those are the patients that we're looking at, right? The ones that are just going to continue. And of course, as soon as a police officer walks in, they go, "Oh no, I'm just sitting here. They're making this all up." I've seen it. I've witnessed it. That's where this bill comes into effect because, as soon as the cop leaves, he's back on. I've seen that too. So this is what I see as the problem that everybody seems to be missing and focusing on the mental health patient who is not going to be the one that we want arrested because we understand they're going through a psychotic issue. So I think you all are missing the point.
Can I address that? I think I hear what you're saying. In the situation that you describe where the person they're drunk, they're unruly, they're continuing to be threatening, I think that person could end up, in terms of how the bill was introduced, it said through actual or threatened violence interferes in the provision of medically necessary healthcare services. I think that situation would be covered. It sounds like that person is only, is like doing this. Police officer walks out of the room, doing it. You have reason to believe that's what's happening here. I think that could give the police officer what they need to do a warrantless arrest without amending the statute. And the risk is that the situation you're talking about, you sound like a really well-informed, well-trained EMT who understands mental health issues. And, what you said about being able, like knowing when to duck, not everyone is as trained or as sensitive or maybe wouldn't be interested in pressing charges as you. And we're legislating for all situations. If everyone could be like you, it might not be as big a problem, right? But we know that
And
that's
I'm gonna
not
tell
the
you,
case.
I'd rather err on the side of the healthcare worker. Right?
I hear what
Because
you're
those
saying.
People have to go to work, stay there, and get their ass beat on a regular basis, and there's nothing they can do about it. That's not good with me.
I hear you. I'm just not sure. At this point, like, let's play this out. If this were to happen, the healthcare workers already sustained an injury.
Yeah, and if he stays, he's gonna get another one?
Well, the person could be charged. If the person presents an ongoing danger, then they could be arrested without a warrant. And I really do think like we need probably to look at this with a broader brush. We have to let this commission, and I don't understand why the commission established in SB 459, which passed last year, is delayed in getting started with its work. But you know, I think hopefully that commission will have some recommendations. The other thing is, I didn't learn until the hearing on this that RSA 627-6 Roman 8 already permits authorized employees at a hospital or any healthcare facility to use non-deadly force when it's needed, when they reasonably believe it necessary to maintain the decorum or safety, and allows them even to use deadly force when they think that's necessary to prevent death or serious bodily injury. So there's already a statutory provision that would allow a hospital with someone who's presenting a continuing threat, like you describe, that is disrupting the decorum and safety of that institution, to remove people. So it's just another reason why you don't have to do necessarily such a broad sweep to cover that unruly drunk person you're talking about, that would also take with it people who experience serious mental illness.
Any other questions? Representative Muse?
Yeah, just a quick follow-up. The statute that you mentioned again, could you once more with the RSA? Ms.
It's
Lilly?
I can talk really fast. RSA 627:6 Roman 8.
Thank you.
You're welcome.
Anyone else have any questions? I'd like to ask, most hospital settings, you delve into training. Now, we're talking medical doctors, we're talking RNs, we're also talking advanced practitioners. These people all have a good working knowledge and understanding of mental health in general to be licensed, don't they?
Well, I'm outside of my lane a little bit here. I think they have a license that in their specialty areas of practice. I don't know what training that they receive in terms of being able to address someone with significant mental health, active psychosis. And that may be one of the reasons that the hospitals joined in intervening in that lawsuit in federal court, where they argued successfully that the state's failure to get these folks out as soon as they're deemed appropriate to be IE-aid is a taking for them. And I think what they argued is that they are not prepared and adequately staffed and compensated to deal with these situations. Our office isn't part of that lawsuit, but I've read the decision and I've read some of the pleadings, and that's my understanding, that the hospitals are saying that they're not fully equipped to, and I would hope that they would be, but apparently they feel that they're not necessarily fully equipped, and helping people to get the training they need is maybe not something that can be legislated. It may be something that is more important some places than others. It may be that some areas of the state have the workforce that has the necessary training and support available to it to be able to address people in such distress, but others don't. It would be an issue for the commission to take up.
Representative Murphy?
Thank you. I just wanted to comment. I was a nurse in a former life and worked primarily in mental health, mostly pediatric mental health and child protection. And I will say, I've made lots of rotations in nursing school. I went to BU and hospitals that I've worked in. And in an emergency room, you've got respiratory therapists, lab people, people from X-ray, and I would be willing to suggest that most of those people do not have a background in mental health. And I often say, I was a great psych nurse, but if you put me on a cardiology unit, I would not be good. I mean, it would not be good for the patients because that wasn't my area of expertise. So we all come to the healthcare facilities with different backgrounds and knowledge. And one of the other things that I'm looking over the input that we've received from stakeholders. I know as a nurse, staffing is often an issue in hospitals, and we do a lot, we cover a lot, and we do whatever we can. But one of the dangers I see in making, first of all, I think this is in the wrong statute to begin with. I'm confused by that. But when the expectation is when security staff is short, and there's a need to deal with a situation, the expectation now would be placed upon healthcare providers to deal specifically with these things. I've been a little concerned that burden might, in an effort to help health providers, we might actually be burdening health providers and putting them in some situations where they're not adequately prepared to deal. And so I don't know. For me, I with all the work that went into the commission and the stakeholder input, I don't know. I think that first Cindy Rosenwald's amendment was the right way to go. And I think this Senate amendment that was not vetted by anybody has just sort of snowballed. And, both are well-intentioned, but I think this second one has created more problems than was original. So I would just like to see us look at that first, the original SB 58, and, see what is it there that's problematic, and is there something that we need to change on that? But I don't know. I think this is it's just convoluted, and it's become a bigger problem with this floor amendment. And when all of the stakeholders had come to agreement in the beginning, on the bill is introduced, I know it's sort of like we're in a, I don't know. I think it's more work that's sort of non-productive because I think it's already been hashed out and people have come to an agreement. So I don't know. Just my take.
Just to clarify, you're referring to the one dated March 29th?
Yes. Yeah.
Okay. And that's one of the things that we looked at as a committee as well. As these are two separate, really, Senate Bill 58 is under two separate statutes. One's under the use of force statute and the other one's under the arrest statute. The arrest statute, to me, seems very clear and concise, and it still maintains the probable cause standard for a warrantless arrest. If we go into the one under the use of force, that gets where a lot of people, I think, lose it and get convoluted with the language. Yeah, that's just my personal take, and I've heard that from other members of this committee as well.
I agree with you in that use of force was really intended for situations where, like a merchant, a movie theater operator, we're not talking, who's being ripped off, not by someone who's in a psychiatric crisis, and also in a situation where they haven't registered, they don't have a band on them identifying who they are, they're fleeing with their property, and there's just not a likelihood that they'll be able to apprehend that person.
But to be perfectly clear, this is just not about everybody who's in a serious mental health crisis. I've spoken with the director of security for Dartmouth, who's the former chief of Lebanon, yesterday. I spoke with the sheriff of Sullivan County and the local chief of police in Claremont, which has Valley Regional Hospital. And they're all concise that this is an issue that happens in their hospitals quite regularly. And they would be very in support of having warrantless arrests for assaults on medical staff in their facilities that they oversee.
I think it depends on, we heard various situations at the hearing, some involving staff on staff assault.
Correct.
Which to me, that's a management issue, not a warrantless arrest issue. That's a deep problem when that kind
Still
of thing.
workplace violence, though.
It is workplace violence, but that's where I get to, like, what's the problem, and are we matching? Is this legislation a solution to that problem? To me, like, when you sort of dissect what the committee heard, that horrific story we heard about the surgeon who threw a blood-covered instrument in the direction of a nurse And when she went to complain about it, was told kind of like along what you said, Representative Peru, good thing you ducked. To me, that is a huge management problem that management didn't have her back. How do we legislate that? How do we manage those on employee situations that should never occur? I'm not sure this is that, right? I think there was testimony about situations with visitors who got disruptive in the hallway and were, yelling at each other. I don't know if there was an assault. I don't remember everything exactly. In that situation, I think that's where RSA 627-6-8 comes into play, which would authorize the hospital to forcibly remove that person who's doing that. So I think we have that situation covered. This is also maybe why the study committee needs to do its work, so that we can really they can get a full understanding of what all the permutations are to this issue. What are all the factors that are impeding workforce safety for our healthcare workforce? And what's the most appropriate way to address those?
Thank you.
Thank you so much.
Who'd like to go first? Thank you. Order, nobody wants to talk? Now everybody wants to talk.
I know.
Just please identify yourself.
For the record, Holly Stevens, I'm the Director of Public Policy for NAMI New Hampshire. I did testify at the hearing. And, I just wanted to say that everybody behind you was in agreement. It is still in agreement that Senate Bill 58, as introduced, is a good solution to this existing problem. And I think it would address Representative Pru's concerns, because it does allow for a warrantless arrest if somebody's interfering with medical procedures. So I think it does address the concerns of people who are intoxicated and, getting in the face of staff and not cooperating, because that is interfering with medical problems, the medical treatment. And, NAMI New Hampshire has heard that people who are there on IEAs are being arrested and being brought to jail. So we do know that that is happening, in addition to all the other situations that we've heard about, but it does happen. And the other thing that I just wanted to bring up, I spoke with our Executive Director, Susan Stearns, at length about this bill. And if the committee is looking at going with the broader detainment language, we would ask that there be a provision, an amendment made, that the hospitals would have to keep track of everybody who was arrested, what their presenting problem was, whether they were on an IEA or not, and that information would be provided publicly, so that we would have a sense of what was going on with that. The Senate Bill 58 language as introduced, we're not as concerned about. So we wouldn't, be looking at any kind of reporting requirements. But if it's the broader language, we would ask that the committee consider reporting requirements.
Thank you.
Thank
Anyone
you.
have any questions? Thank you.
Thank you again for allowing us to speak. So a couple things were stated by Ms. Rosenberger that I wanted to clarify. So the Workplace Violence Prevention Program, I think my testimony indicated this, but I know you guys have a lot of bills. So Senate Bill 459 was passed last year, signed into law by the governor. He had a signing ceremony. That's how important it was at Frisbee Memorial Hospital, at Senator Gray's hospital, because of the importance of this. That is in 15153, Workplace Violence Prevention Program. It outlines very clearly what the hospitals require and hospitals and urgent care centers are responsible for. And they are responsible for doing training, de-escalation, et cetera, et cetera. So I just want that off to kind of just clarify that they already do this anyway, but now it's documented in the statute. The commission is a separate statute, and that is under 151J, the New Hampshire Healthcare Workplace Safety Commission. Again, there are 4 sections of 459. 3 passed, 1 did not, and that's why we're here to talk about 58. So the Workplace Safety Commission is not a study committee, as was indicated. This is a permanent, if you will, not permanent, nothing's permanent, but this is a commission that will be ongoing and not legislators involved. Every single hospital has a seat on it, and every single urgent care center has the opportunity to have a seat on it, as well as the Department of HHS, Labor, has a seat on it. The Attorney General's office has a seat on it. New Hampshire Hospital has a seat on it because they are not licensed the way the other hospitals are. And 3 members at large. And for instance, we would like to have like a nurse from the Nurses Association appointed, for instance, that works in a hospital, or just that's what we have requested. The commission, all of this was delayed for a very valid reason. And this was all negotiated last year in the House Finance, when it was in House Finance. It's moved to July of 23 for a good reason. The Department of HHS, which is where this falls, needs an appropriation, needs a staff, because the commissioner would be responsible for rulemaking to get the terminology correct on the form that will be needed for every single facility by law that would have to fill out every single assault. You have to fill out a universal form. And because one of the reasons that came out of the study committee was we don't have consistent, accurate data, and we want that for the commission, which will be protected by privacy, just like the Quality Commission is, which is also a permanent commission. They would be protected and have a discussion about best practices, what the situations were, and then maybe come back to the legislature and ask for further changes, or just develop protocols, working with law enforcement, working with with whoever is appropriate, with the Attorney General's office and the department. So those are very important components that are already in law. So I just wanted to clarify that. And then I guess it was stated by Ms. Stevens, and I appreciate that. Senate Bill 58 was negotiated by all stakeholders. I'm not quite sure where the DRC stands now. I heard a lot from her, and I thought that they were fine with Senate Bill 58 as introduced, but that was my understanding, and they did not testify during the Senate phase. The difference, again, is what has changed because of the floor amendment. But Senate Bill 58, and I agree with Representative Murphy, we call it the Rosenwald Amendment. The amendment that was introduced and did not pass on the floor makes a minor change to the way 58 was introduced to clarify, because one of the concerns was we didn't want, and I've talked with some of you about this, we don't want law enforcement having to make the determination of medical necessity. That was never our intent. So to move the determination to be medically necessary to the end of the sentence, that's where, that's the Rosenwald Amendment, which is 1251S, which I know is in your docket for this bill. So we agree, we did have an agreement. The problem is it did not pass the Senate. But if you believe this is the more appropriate approach, I continue to work with, I talked to Senator Gray last night about this. Everyone's very interested in this. As you know, it made the union leader yesterday. So, I talked to Senator Whitley last night. I talked to another senator. They all care about this bill. We will work, whatever you pass, if it passes the House, we will work to get, and I know you will help me, get this through the Senate. If it means 58, the Rosenwald Amendment, if that makes more sense, which again, you have stakeholders behind you saying that would work. I think you guys are the professionals. You've been in this field. If you believe this would work, law enforcement believes this would work. They can't speak on this bill because they don't have universal agreement. But I think you've talked to some law enforcement. They believe that this could work. just wanted to help clarify a couple things.
Representative Mannion?
Thank you. Thank you for taking my question.
Sure.
My question is about the healthcare provider or his agent, it's section 3.
Are
And
we
you-
looking at the bill as amended?
Yes, we don't
Representative?
have a copy of the original Senate bill. We only have the amended version of it. So when people are speaking about
Okay,
that, we
okay.
don't have that copy. So that part there doesn't it talks about agents, which would cover security officers.
Right,
I guess
exactly.
one thing that's on my mind is, are there scenarios in your experience or testimony that you've heard that there are healthcare providers that do not have security?
Good question. I think Mr. Patty referenced some hospitals, small hospitals contract security. They're not as large as CMC, so they don't have personnel on staff, so they contract with them. Unfortunately, I don't know that I'd have to survey the hospitals, but I don't believe that they're 24/7. So they have security. I just worry that they don't have full-time security.
All right. So I guess my question is, let's say it's one of those smaller providers, doctor's office, because this says healthcare provider. That would cover
Yeah,
any
I wanted to clarify that too. I think someone,
urgent care, things like that.
it's
So,
only in not doctor's offices. This statute would not, well,
so it's specifically, well, with the RSA 151.2 would I guess identify which ones would be covered.
right.
Would that also cover urgent care facilities?
151.2, yes,
we
I
have to look
believe
that
it
up.
does, but not doctor's offices. They're not licensed under health facilities. Doctors are licensed as their clinicians, but their offices are not. So offices would not be, this would just be, I have to pull up the statute and I should know it by heart, but it does include urgent care in hospitals and ASC,
what
ambulatory surgery centers.
What I'm trying to get at here
Yeah.
is, what protection do we provide to healthcare facilities covered under that statute that don't have security, where they may have healthcare providers that use physical force to detain somebody, and they're no longer protected under this statute if we remove that part of the bill? So I'm asking you, should we still include that justification for force for healthcare providers, nurses, doctors, orderlies? I don't even know if that's a term that we use anymore, and not just security guards?
I think I need John up here.
Okay. And I know I asked John earlier, I just didn't know if we should also keep that part of the language for that reason.
What is here? I think he's talking about the use of force,
Yeah.
the other one, which is, where is that?
That's under 627.
627, thank you. Let me pull it up.
So earlier I asked you about, and you didn't see a need for that to be in there if you're already justified under the law that passed a few years ago. But my concern is if there are no security on staff, a smaller place, should we still allow justification to protect healthcare providers that may use physical force to defend themselves or to detain somebody?
So yes, in my opinion, yes. Oh, thank you. Two different matters, right? So, the RSA under 627.6 Roman numeral 8 is not just for assaults that occur, right? Sometimes security has to escort patients, back to areas, right? And we didn't have any protection, statutorily to be, physically grabbing people and bringing them back to a room. So that was that intention of that. But to your point, yes, as I said before, everybody has the right to protect themselves, and this just clarifies it for me. So yes, short answer, I would say yes.
Thank you.
Representative Wheeler?
So you support SB 58, the Rosenwald amendment, or as amended by the Senate?
Rosenwald is what we agreed to last year as part of SB 459.
Just to clarify, that's the one dated the 29th of March? So everyone's on the
Yes.
same page.
Yes.
Okay.
I have a copy if anyone needs that.
Do you need a copy, Jonah?
I do, if actually, could I get it? Can I get a follow-up also?
Yep.
Can I just augment a little bit?
Sure.
We are not opposed to 58 as amended by the Senate. We could live with it, but we are not. It is not what we all agreed to. So again, it is so important that our healthcare workers be protected. We need something to pass. I know that is not a universal position, and you have heard testimony not supporting the amended bill. We think 58 as with the Rosenwald amendment, to clarify, that works better, but it did not pass the Senate. So that was our concern. But this is a new body. This is a new opportunity to get it right. And then whatever changes, then we would work to get it through to the Senate. But we all worked very hard on Senate Bill 58 as introduced.
And a question for you. I've been hearing a couple of different things. I think the representative from the DRC mentioned, I know Representative Muse wrote down the RSA number. I didn't have it. It started with 6, but it's allowed, from her testimony, it allowed you to use physical force or even deadly force if necessary to restrain a patient. And that, by her testimony, was already in statute. So I'm a little bit confused by it. I'm seeing that you already have that power based on the testimony from the DRC.
Sure. So, different scenarios, right? So, yes, we have the right to detain somebody, but we don't have the power to arrest, right? We're looking for the police to come in. When I call the police, I want them to be able to come in and make that determination and be able to arrest that patient without applying for a warrant under a misdemeanor level offense. Two different matters.
Can I get a follow-up? So if someone was detained and the police came, you're saying that they would let that person go or not get a warrant to arrest them if that person was detained for using physical violence against the healthcare worker?
They have that discretion. They don't, this isn't a mandatory arrest. We're not asking for that. So the police have the discretion to make that determination at that point, whether or not they're going to arrest that person. A lot of times, if I could just continue, a lot of times they don't make a decision to arrest because, one of the limited exceptions under 594.10 says that the person will, continue that behavior or act out again, right? And as I testified to before, I don't understand putting a victim in a position where they have to be assaulted again to give the police the justification to arrest.
No further questions.
Representative Brew.
Do we know why the Senate didn't like the Rosenwald and they decided to go with this? Was there something in this that they said, oh, we don't like that and we need this instead? So I'm kind of trying to figure that out so we could
I'll let Paula
maybe
speak to some of it, sure.
maybe smooth that over for them and
Yeah.
give them a version of this that is tolerable.
Yep. Some of this happened behind the scenes without our knowledge. So we know that there were concerns. It went to Senate Judiciary. We know that there were some concerns relative to, again, the determination of a service being medically necessary. We worked on that language, again, with stakeholders. It was important that it be in there to ensure that we were talking about services that were being provided that are medically necessary to kind of to limit. Yeah, we wanted to be very limiting as far as the application of this. And I think one example could be if you are have been IEA'd and you are waiting for a transfer to a DRF or New Hampshire hospital, you may not actually be getting medically necessary services because you have already been determined that you need to be transferred and unfortunately you're boarding in the hospital. Right. That's why we believe that it was very important to include that. Some senators had a little bit of heartburn with that. That's why we moved the language to the end of the sentence because 58, hold on, as introduced. Sorry, hold on, I have it. I have a very big file. let's see. Oh yeah. The, as introduced, was while in the care of a medical professional on the premises of a residential care or healthcare facility as defined in 151-2, through actual or threatened violence, interfere with the provision of medically necessary services. So what we did, the Rosenwald Amendment just interferes with the provision of healthcare services, and then we moved it to that a licensed medical professional has determined to be medically necessary. Some of the arguments by some of the senators was it would be law enforcement's determination that it was medically necessary, and we're like, no, that's not what that means. Because it would be in the medical record. If it went, they were kind of jumping to if it goes to, if they press charges and go to court. We were just talking about actually, as John has stated, just getting law enforcement to act and without a warrant. So that's the piece that we were trying to focus on. So we thought, well, we'll make it really clear. So we were there, and then, but it still wasn't, not everyone was comfortable. And then this floor amendment was, so the vote in the Senate was delayed a number of times to try to get to a place that folks could be comfortable with. And that's where the floor amendment came in. And again, not everyone saw it, and not everyone is ultimately comfortable with it. It was a creative approach. It just, we're not sure that it hits the mark the way that we thought 58 would. But it did. The Rosenwald Amendment failed by one vote. Or two votes. I should say two, because it would have been even. And Senator Gannon was missing at the time, so it was an 11-12 vote. So a 12-12 would have failed, of course, but it failed by two votes. So it's not insurmountable, I guess is
so
my.
It wasn't like a huge, we're all against this.
No, not at all, not at all.
Any other questions?
Just did want to say, just reading the Senate report from the original public hearing, it looked like one of the senators had a question around whether or not the original bill would apply to places like cafeterias, and thought that perhaps it needed to be a little bit broader, which may explain the floor amendment, which is much broader. And I think where we have the difference of opinion is whether or not the bill should really be structured around situations where medical services aren't being provided because of disruption, or if something is needed that basically would apply everywhere in the entire facility, which it seems like New Hampshire law already would cover.
It would, and I'll let John touch upon that, but that would be considered trespassing. If you're in the cafeteria and you're just start throwing things because you're frustrated because your loved one is in the hospital and for whatever that you're a guest in that private facility, you could be escorted out. So we don't, and it was intentional to be very limiting, as has been stated. So we don't want it to apply across the institution.
Yeah, I would agree. She hit on it. There's New Hampshire statutes are really, most of them are crafted very well. And we have, not we, I'm not police anymore. Police have the power to remove that type of person from a cafeteria, if you will. I don't need to go into all the details, but yes, she's right.
Thank you.
Any other questions for anyone? Oh, Dennis.
It's not really a question, but I want to have your input as I talk about this. So there's three separate things going on here. I know there was confusion about why it was in physical force. And we talked about the amendment of the law from last couple of years ago that gave you guys permission to use deadly force or non-deadly force. The three things going on here are detaining somebody, using physical force, and then a warrantless arrest. So I think the Rosenwald Amendment doesn't talk about detaining somebody or giving anyone the authority to detain. The amendment, SB 58 as amended, talks about detainment and use of physical force. also covers warrantless arrest, but probably not as good as a Rosenwald amendment does. I don't have the original copy, as I said. So depending on which one we go with, some of them are missing some elements. Some of them don't allow for detainment by hospital personnel. Some of them don't allow for justification of physical force by hospital personnel. I think this floor amendment only covers warrantless arrest by officers. So we're missing two other elements there that I think may be important still in the bill.
So great point. Thank you. So ultimately, I think Paula already alluded to this. It was the floor amendment was a creative approach because there were some concerns with the language in the original SB 58. As far as the detaining portion and the physical force portion, elements of that, they're not needed in this statute. There's other statutory protections out there. Ultimately, no matter where we want to hide this, it is about a warrantless arrest. That's all this comes down to, is giving, and it's not even additional a warrantless arrest powers. It's just clarifying a circumstance in which the police can do it. So that was the intention of the limited scope of the original language, right? We didn't want it to be too broad, to concern others. So you're right. You're spot on. That language is not necessary.
Thank you.
Thank you.
Thank you.
Yeah, you can keep it. I got extra copies.
Oh, this is the,
Yeah, it's the use of force.
Thank you. I'll be really brief. This is Karen Rosenberg again, Policy Director, Disability Rights Center. I want to clear up ambiguity because apparently was not clear. The language in the Rosenwald Amendment is acceptable to the Disability Rights Center. It's very close to what we had all worked on together and the bill is introduced. And we were consulted prior to the moving of the languages Ms. Minahan described to you. So just so that you all know, we are fine with that language. And I thank my colleague, Ms. Minahan, for pointing out the difference between what passed and what didn't pass and what's in effect and not in effect right now and moving forward. I do want to point out that the commission that was created, that's now in 151J2, that hasn't been able to start its work yet, will be also looking at supporting the development and implementation of healthcare workplace violence prevention programs, including training. So that is in there. So I know that hospitals are working to do this, but there's also more work to be done. So I wanted to clarify that, and that's really all I wanted to say.
Thank you for the clarification.
Thank you.
Anyone else have anything they want to add to this discussion? I take it no one here is from motion picture and theater orders for this bill. Okay. What we're going to do is we're going to take a recess and come back at 11:40. We are back in session. I want to recognize Representative Muse for a motion.
Thank you, Mr. Chair. I am proposing Amendment 2023-1490H to SB 58.
Second. Beat ya.
I think Mr. Prue got that one beat off. So, Representative Muse, could we get a roll call?
Sure. Did you want me to explain the
Oh, I'm
amendment?
sorry.
or-
Yeah. Trying to get ahead of myself here.
That's okay.
Representative Muse will go
Sure.
ahead and explain.
What the amendment does, I think we want to say, we heard you. There were some definite concerns with the bill, the way that it came back amended from the Senate. And one of the things that we realize is that sometimes our process, both in the House and the Senate, doesn't necessarily always allow for the degree of public input on some of the things that we do that we would like to see, especially when it comes to floor amendments. So in effect, today we had a public hearing, the public hearing that we didn't have on the bill as it came through from the Senate. So I want to thank everybody who came out today. I think this has helped us get to a better place. In anticipating, based on the public hearing, where this might go, I had prepared an amendment in advance, and it looks like this is where we've wound up. What the amendment effectively does is take us back to the original bill as it was submitted and incorporates the Rosenwald Amendment. And we believe that this will address the concerns of the medical community. It will provide police with the power to make a warrantless arrest in these situations. Hopefully, our medical personnel across the state will feel a bit safer in these situations. I think we realize that there's a lot of other stuff that needs to be done in terms of things like housing mental health people with mental health issues in emergency rooms, and there are, I think, increasing the safety of our hospitals is an ongoing work in progress, but I think this bill could be an important part of the picture. So I'm happy to introduce this, and I hope we can make a recommendation to the full committee to pass the bill with this amendment.
Thank you. Representative Prue, would you like to add anything to your second?
We were kind of along the same lines, and Representative beat us to the punch, and I'm glad he did, because I didn't have to go get the amendment. So pretty happy about that. But this is, and like you said, we heard what you were saying, and we kind of agree that this is much cleaner, much neater, and exactly what you guys all agreed to. So we're glad to push this forward.
Representative Wheeler?
She was robbed of the second. No, I think that this is absolutely the appropriate solution. I think it's been here sort of all along. I thank Representative Muse for going ahead and getting this amendment made. Stakeholders are in agreement. I think those of us who have a sense of how hospitals work and we want to do something for health providers because we know it's an issue, but we also want law enforcement to be able to use discretion and to take action when they need to, and I think this certainly allows that to happen. And I'm sure down the road there will be gaps or holes that will need to be addressed, but those things can happen. But at least there's something immediate, and I'm happy to support this.
Representative Wheeler?
Well, I just want to add on to what's the great things that have been said and totally agree. I'm thank everyone for coming out today. This is clearly an important thing. My grandmother is a nurse, and I know very clearly that there are situations happening in the hospitals that need to be addressed, and I'm happy to come together on a bipartisan amendment to address those. I did just want to weigh those concerns very carefully with what was brought up by the DRC and NAMI, which are completely valid concerns of not wanting to criminalize mental health further than we already have in our society. And I think hopefully this opens up a conversation about not waving our magic wand, but starting the slow and arduous process that is the sausage making to get robust community-based services so we can hopefully avoid in a preventative way this problem without further criminalizing people. But I'm happy to move forward in support of this amendment because I know as grandson of a stakeholder how important this is for our nurses and our healthcare workers in our hospitals. So I'm very happy to move forward with this, and I'm glad we've made that distinction. I know Representative Prue is about to. What's up?
Your grandma's gonna be so proud of you.
She's gonna be so proud. She already is. No,
Anyone else? I'd like to say that we recognize the importance of this issue, and the bipartisan support hopefully will continue in our full committee and then on the House floor. I think this is probably overdue, and it's time that the Criminal Justice Committee hopefully will start taking a more proactive response to some of these issues been coming before us. I know we've had some people been very upset about the retention of all our bail and judicial bills that we've been holding, but this one I'm very comfortable should move smoothly through our full committee at this point. And I'd like to thank you all for giving up some time this morning to come out and join us. With that, go ahead and
need to vote.
do the roll call. Yeah.
Now.
Did you want me to make the motion?
No, you already made the motion. You do the roll call.
So the motion is, we're voting on your motion.
Voting on the roll call.
You just call it.
So we just have to vote.
Roll call on the motion to pass,
second.
and I guess I should,
Okay, I thought
never
that-
having clerked
I'll
here.
I'll call the roll.
I think I need to
Representative
call the
Wheeler?
roll. There we go.
Aye.
Representative Murphy,
Yes.
Representative Prue,
Yes.
Representative Moose,
Yes.
Representative Mannion,
Yes.
Representative Tenzar,
Yes.
and the chair is a yes.
We are 6-0. Unanimous.
Thank you all.
Thank you.
No, thank you.
And with that, Senate Bill 58 is now closed.